Good evening once more, everyone. My name is Moraa Abuya. I'm an anesthesiologist working at Kisi Teaching and Referral Hospital, and I'll be your moderator for the evening. I would like first to appreciate the Kenya Society of Anesthesiologists, KSA, webinar organizing team for organizing this topic that had generated a lot of discussion of late. I'd also like to thank all participants. So far, we are at 175, which is commendable. And I think we are ready to begin. But before we do so, a few housekeeping rules. First, let's have all our mics muted so that we can give full attention to the speaker of the day. You can use the chat box for your questions and any comments that you may have. And I'd also like to thank the day sponsors, that's Abbvie. And we have Anthony Njau, the regional manager, with us. And at the end of the discussion of the day, he'll give us a brief presentation. So without further ado, I'd like to introduce our speaker for the day. And very few of us will require introduction to Dr. Kabetu. For those of us who don't know Dr. Kabetu, that is him. I think that's the best picture I could find. Dr. Kabetu is a guru, I would say, of so many things, but just a brief introduction. He did his MMed from the University of Nairobi, finished in 1987, and has been served as a consultant anesthesiologist at Kenyatta National Hospital until his retirement in 2016. So he gave uninterrupted service for 33 years, quite commendable. And he still has to tell us the secret of looking so young. All right, he was also the honorary lecturer in the Department of Anesthesia and Critical Care at the University of Nairobi during that time. Currently, he's the adjunct professor of anesthesia and critical care at Jomo Kenyatta University of Agriculture and Technology. He has participated variously in very many things, has been a past chairman of KSA. He's a member of the British Obstetric Anaesthetist Association. He's also the regional medical officer of Operation Smile, which many of you are familiar with, for Ethiopia, Kenya, Ghana, Malawi, and Rwanda. And he has also volunteered in the same Operation Smile since 1987 to date. He's been a trainer, and I've had the privilege of working under him, of anesthesia providers, both at the University of Nairobi, the Kenya Medical Training Institute, and currently working with Jomo Kenyatta University. So with that brief introduction, I'd like to hand over to Dr. Kabetu to take us through a low-flow anesthesia, the basic principles and how to handle the challenges that come up with the monitoring and how to interpret the data. So Dr. Kabetu, karibu.
Thank you. Thank you, Dr. Moraa, for inviting me to and giving a brief description of what I have been doing since I started interacting with the patients. I put the banana plant to identify with you coming from Kisii.
Thank you.
Now, this is a brief history of what we have been dealing with in terms of anesthesia. You can see here, this is the oldest method of giving anesthesia or performing surgery. This is a patient, I presume, has a fracture and a very big container of a liquor to make him go into stupor so that he could be operated on. But modern anesthesia, as we know it, is when it was given by Morton. And you can see there were more observers in the room all the way. And I think they were either taking care of the patient, monitoring the anesthetist. And at the end of the day, we identify ourselves with first that day when modern anesthesia was given with either. Then we are familiar with the EMO machine, which has been in use for quite a while. And then Boyles. This is how I got introduced into anesthesia. The Boyles machine had fluorometers with oxygen, nitrous oxide on the other end, and in between there was carbon dioxide and there was cyclopropane. So 4 fluorometers in one. And then the vaporizer was actually made of glass. So there was no temperature control or compensation. Then we moved on, we go to the temperature and flow compensated vaporizers. And this is one of the ones we used to use for halothane. And from 18, that time that the first anesthesia was given, and the current time that we have, this photo was taken on Sunday, we can see that we have very few of observers in theater in terms of monitoring the patient. And we are now monitor most of our patients with very modern anesthetic machines. And I was thinking, if we have moved these in terms of modernization of our machines, why can't we also be able to go low on our flow? Now, these are circuits that we have used from time immemorial to deliver inhalational anesthetic agents. What we are seeing here is an open system, which is actually cotton wool or cotton gauze that was used to absorb the ether, and the patient was breathing through, and the vaporization of the ether depended on the patient's respiratory effort. So that if the patient decided not to breathe, there was no way he was going to get either ether or chloroform. If the patient decided to breathe deeply and too much, then he would fall deeply into anesthesia. There was no other way of knowing how much you are giving other than monitoring the patient and looking at the depth of anesthesia in terms of the way we were trained the stages of anesthesia. Then later, this was the open method, whereby you could not actually be able to know how much you're giving to your patient. Then we came to the semi-closed circuits, and this is one of the circuits we used a lot. This is Mapason A. It was a very wasteful circuit. You can see this is where the fresh gas flows come in. This is an expiratory valve, and this is where the connection to the patient's mask, and it needed 1.5 times the minute volume for you to avoid rebreathing. That time when we were training, rebreathing was criminal. We were to avoid rebreathing as much as possible because of carbon dioxide accumulation and all the things we know about carbon dioxide. Then this is the pediatric circuit. This is IRTPs with modification of Jackson Lee's bag. And again, this is another wasteful circuit whereby you have to use the patient's 2.5 times the minute volume. And you can imagine if this is where your expiratory valve is, how much of waste and how much of contamination of the operating room we have. Then this is the closed circuit or the cycle circuit, whereby fresh gas comes in, goes to the patient, and when the patient breathes out, it comes and there is carbon dioxide that is absorbed, water vapor and heat is preserved, and then you require very little or very minimal of fresh gas coming in because you can be able to rebreathe. And this one has been found that you need or you can use less than the patient's minute volume for you to be able to attain good anesthesia. Now, how do we do our settings and how have they been classified? Very high flow gas, very high gas flow, fresh gas flow is more than 4 liters per minute. And I can tell you for many years, this is where we were all in terms of our settings. I remember we used to set our oxygen at 3 liters per minute and our nitrous oxide at 5. So we used to give a total of 8 liters of your fresh gas flow. And I'm told up to today, like 80% of us are still using very high fresh gas flows. Then high is between 2 and 4. Moderate is between 1 and 2 liters per minute. Low is below 1. So any of us who is using flow which is below 1 has actually been able to be converted to a low flow anesthetist. Minimal is between 0.25 and 0.5, not 5, but 0.5 liters per minute. And metabolic, what we call the metabolic of basal fresh gas flow is 0.25 and below. And as we are going to see, this will depend more on the basal metabolic requirements that we have for oxygen. Now, basal oxygen requirement becomes important because sometimes we mix oxygen with nitrous oxide or air, or the three of them. And the uptake of oxygen and utilization of oxygen depends on the metabolic needs of the patient. This has been calculated to be between 3 and 5 mL per kg per minute. And therefore, the oxygen needs, as far as we think of setting our flow gas, depends on the weight of your patients. And we can see from here that we actually give a lot of oxygen to our patients, which is not needed. 100 kilogram patient will require about between 300 and 500 mL of oxygen per minute. So when you're doing your settings, half a liter per minute of your gas flow is enough for 100 kilogram patient. When we come to a 3 kilogram baby, you find that they require mainly about 9 to 15 mLs of oxygen. And which makes me start thinking, when you are giving a small child 1 liter per minute of a fresh gas flow, how much damage are we doing to our small babies? Now, a bit of concept of most of the, where our discussion is going to narrow down to, we have what we call greenhouse, atmosphere, greenhouse gases, and global warming. And as we are going to see, there's a lot that we as anesthetists contribute towards global warming and towards the emission of greenhouse gases. Now, this is just the concept of greenhouse. Of us who have been interested, those of us who have been farming, those of us who have been traveling around the country, we know a lot of greenhouses in Laikipia. We have a lot of greenhouses in Kajiado. And the concept is you have a structure that has a roof and walls. And the idea is to contain the climate in it so that those plants that require controlled climate can be grown into or in greenhouses. It is able to get sunlight. It is able to preserve energy and heat, and you avoid the freezing temperatures. And most of the Western world where they have winter, they have survived a lot because of greenhouses. They are able to grow their vegetables, their food in greenhouses, even when their temperatures are zero, because the greenhouse can be able to conserve the climate. And I'm thinking that is how, when the world was being created, that was the issue of having the earth covered by an atmosphere that works as a wall that is able to absorb heat and prevent harmful rays from the sun getting to us. It also contains oxygen, which we breathe, and carbon dioxide, which the plants use, that there can be survival of both plants and animals. And the ecosystem had been set in such a way that when human beings are producing carbon dioxide, and then the carbon dioxide is used by trees, by plants, and then the plants during photosynthesis, they release oxygen. You can find that is a continuous feedback system. And it also helps to trap solar energy. But what has been happening is that due to greenhouse gases, and the main culprit is carbon dioxide. Carbon dioxide contributes to about 81% of the greenhouse gas emissions as estimated in 2018, followed by methane, followed by nitrous oxide, which has taken over from the fluorinated gases, which actually used to be the main culprits in terms of greenhouse emissions. Then we have got our fluorinated anesthetic gases that contribute to about 3% of what was estimated then in 2018. Now, when we look at the way we anesthetize our patients, when you give a mixture of oxygen, air or nitrous oxide, and an inhalational agent, when that mixture goes into the body, the cells use oxygen for metabolism to produce energy, and we expire or we exhale carbon dioxide and water vapor. But the agents that we use, like halogen, 70% is expired and changed, and we only metabolize about 30%. Enfurulane, 80% is expired as a gas. Isoflurane, 99%, sevoflurane, 95%, and desflurane, 99%. Meaning, other than the action the inhalational agents exert on our cells to produce sedation or to give their activity, most of those gases are expired. And I'm trying to think that if all these gases were to be expired, these volatile agents are to be expired into the atmosphere, how much of damage are we doing to ourselves and to the environment? Now, a bit of global warming. Global warming actually means that it is gradual heating of the Earth's surface, the oceans, and the atmosphere. And this has been gradually happening. But it has been found to be #1 threat to human health. And in fact, now WHO is looking at sustainable ways of conserving the environment by looking at the medical wastes and how much we are releasing into the atmosphere to prevent or to reduce global warming. It started about 150 years, and that is the time industrialization started. And with industrialization, two things happened. We started using fossil fuels for our activities, driving cars, running workshops, running factories, and we started emitting a lot of carbon dioxide and a lot of other gases, the greenhouse gases, into the atmosphere. And we also started doing deforestation, because once we started putting up cities and houses, we realized that we are also reducing our forest population. And this has overwhelmed the atmosphere in such a way that carbon dioxide, the one that was supposed to have been used as in the ecosystem, has been increased. If you add this to the anesthetic gases that we produce, if you add this to the other emissions of the fluorocarbons that were found in fertilizers and they are found in plastics, you can imagine how much damage we are doing to our world. Now, this is just a slide showing the global warming potential as defined by the energy that is added to the climate system compared to carbon dioxide. And it is given in carbon dioxide equivalents. And carbon dioxide has been used as the basic unit. So it has got a global warming property or potential of 1. Now, the inhalational agents that we use, as you can see, sevoflurane has got an equivalent of carbon dioxide of nearly 4,000, and it has an atmospheric life of 2.5 years, meaning it doesn't do a lot of damage because it is going to be removed from the atmosphere within 2 years. Isoflurane has got a potential of about 5,000 compared to carbon dioxide, and it is atmospheric lifetime is 3.5 years. Then desflurane has got nearly 70,000 equivalents of causing global warming potential, and it stays in our atmosphere for about 10 years. Nitrous oxide has been found to be the biggest culprit because it is nearly 10,000 the equivalents of carbon dioxide in terms of the potential to cause global warming, and it stays in the environment, in our atmosphere, for 121 years. So when I think of the 30 years I have been using nitrous oxide at high flows, which is still going to be there after I have left this earth, it tells us how much damage we have been doing to ourselves. So nitrous oxide has been found to be the third largest greenhouse gas. It causes both global warming effects and ozone layer depletion. So what it means is that ozone layer, which is supposed to be protective, once you start poking holes into it and creating holes, you are again allowing more of the ultraviolet lights, which are supposed to be absorbed by the by the atmosphere, getting and becoming harmful. And it has also the longest life in the atmosphere. Now, all these, I just need to present a case of a patient, or several patients have been able to do, but I picked this one so that we can be able to appreciate about low flow. This was a 3-year-old boy, 17 kilos, with a height of 93 centimeters, a hemoglobin of 12.2, with no other comorbidity, a febrile. We had even tested for COVID and was COVID negative, who was coming for full mouth restoration because of dental caries. Now, why I chose this case, because it's a case that takes about 3 hours. And within those 3 hours, you can be able to appreciate and you can be able to see how much of low flow one can be able to give, manipulate the monitors, the machine, for you to be able to avoid all the complications that we know or that has been cited for low flow. This is a patient I induced to intravenously because luckily the patient came with a line from the wards when they were taking the blood for investigations. He had a gauge 22 on the granula. So I gave glycopyrrolate 0.2 mLs, gave propofol 40 milligrams IV, gave morphine of 2 milligrams, gave dexamethasone 4. Then I gave antibiotics, the 300 milligrams of cefazolin. I gave Votalin, the 12.5 milligrams per rectum, and paracetamol 375. And this was to make sure that we are covered both pain-wise and antibiotic-wise. So this patient we induced at 11:10, and the operation took 3 hours up to about 2:15 there. And we were able to be constantly maintaining the patient on 0.1 liters per minute of oxygen, monitoring our blood pressure, systolic, and with our heart rate. We were also monitoring the oxygen that the this is the inspired oxygen, or FiO2. I also monitored the saturation, SpO2. I monitored the end tidal CO2. I was also monitoring the pressure that the patient was getting. The inspiratory was on pressure controlled ventilation. We had said we could be able to get the ideal calculated tidal volume and minute volume of 126 mLs tidal volume. Tidal volume of 2.7, 2.9. At the end of the operation, this is a patient I put a tube 5.0, which was fitting very well. There was little leakage, But again, this is a patient we had to pack. Restoration is that there is quite a bit of irrigation that is done. We also wanted to prevent debris, prevent the filling materials getting into the airway. So a throat pack is always important to put, and we always have to mark when we put a throat pack, and we control ventilation. And at the end of the day, we gave 100 mLs, not 100%, but 100 mLs of ligasractate, and we had minimal blood loss. Now, so this is our patient, already intubated, and the surgeon progressing with the activity of restoration of the mouth in terms of fillings and in terms of putting crowns and extracting whichever teeth and roots that are not going to be or are going to be harmful to the patient. Now, this is the ventilator settings and the respective routine, that is the ventilator pressure, and I was able to get my tide of CO2 of 35. This is the pressure the machine is picking. This is the volume. We are also monitoring the input of our oxygen. FiO2 had come down up to 24%. This is what the expired and expired, and this is the mark, the mark value, mean deep, because you can be able to see the mark value. This is an econometer that is able to tell you when you are going above. Hello?
Yes, we can hear you.
You can hear me now?
Yes, much better. Thank you.
We still have people with we still have people who have got their, I don't know whether it is going to consume the, so this is the screen that is on the ventilator side of the anesthetic machine, setting at 50% of air and 50% of oxygen, giving
Dr.
a total of 0.3. Yes.
Sorry to interrupt you. Now we have you clear. If you could just start from the current slide, just from the beginning of this current slide.
The whole of it.
Just this current one, yeah. Just the whole of it, yeah. Because we didn't get, yeah.
Sorry. So this is the patient I was presenting. This is intubation through the left nostril, tube secured at 16 centimeters from the tip of the nose. That is calculated when you take the age of the patient, divide by 2, add 15, for you to be able to be at the mid of the trachea. And this is the surgeon now performing the operation, drilling. They do a lot of drilling, they do a lot of excretion, irrigation. And at the end of the day, and this is the screen showing the ventilator settings. So I had set the ventilator setting as 50% of oxygen and air, giving a total of 0.3 liters per minute fresh gas flow. Our patient is on pressure controlled ventilation with a pressure of 13 and a respiratory rate of 20. And it is giving us our calculated, our intended tidal volume of 139, with a minute volume of 2.7 liters per minute. Our CO2 is 35 millimeters of mercury. Then I'm trying to, yeah. Then on this end, this monitors the inspired oxygen that we are giving to our patient, FiO2 of 0.24 and expired 0.19. I was not using nitrous oxide, that's why it is 0. Then the isoflurane is at 2%. The inspired and expired is 1.8. And our mark value is at 1. And what I was saying about this is that this is an econometer. Once you are within the green, it tells you you are not being wasteful. You are actually being quite efficient. If it goes above, it tells you that you are being wasteful. If it goes to red, it means that you are not giving enough. So it is a very good machine that tells you, and it is able to monitor for you and tell you how much you could be doing in terms of either you are insufficiently ventilating and providing your patient with the proper gases and the proper mixture, or you are overdoing it. Then here is our patient's monitor. We are able to have our trading of our blood pressures, our saturations, and our heart rate. And this is at the waking up. As we are going to see, what happens is that when you are using low flow, you find that most of the circle system will have a high concentration of the inhalational agent. So you have to push to put out or to go and use your external out of breathing circuits, the one that was using the cycle. So this is an IST piece which I have connected just direct, just to give oxygen, so that you can be able now to start the reverse. Because now the reversing of the patient, because I had not paralyzed my patient, the reversal is actually now breathing out the isoflurane that was in the system. If you continue with the circle system, it means that there is quite a bit of it that is left in the circuit, and your patient will take longer to wake up. So those are the adjustments one has to do. If you don't do that, you need to flush the circuit. Sometimes it has been advised every 1 hour, you flush the circuit so that you can be able to drive out the excess of the inhalational agents when you are waking up. Now, what are the disadvantages of low flow? And since we started posting as teasers, this is how you can, we are trying to give zero flow anesthesia. There was a lot of concern in terms of 3 things. One of them is awareness. The other concern was to do with patients getting hypoxia. And the other concern was accumulation of CO2. And all those are possible. And what I tell myself is, if I have to be a corridor anesthetist, I cannot be able to give low flow anesthesia. You have to be in theater, you have to be seated next to the patient, you have to be monitoring the patient, you have to be checking what the surgeon is doing, because any change in the equilibrium is going to interfere and it can have disastrous results to your low flow. So low flow is not for people who anesthetize their patients and they go for tea or they go for coffee or they take long bathroom breaks. You have to be there, you have to be your patient, you have to be that anesthetist with a very big bladder, a very small stomach, so that you don't have to keep on walking out. So you are able to sit in theater 3 continuous hours, 4 continuous hours, because you know the benefit. So one of the things is that when you're using low flow, if you have to use induction, inhalational induction, it takes longer for your patient to be induced, because you find that there will be very little of the inhalational agent in low flow. How you can avoid this is either by giving by starting with high flows after you have induced your patient, now you can go maintenance low flow, or you can flush the system with a high dose of the inhalational agent. So what I would normally do, I will take my isoflurane, dial it up to 3 or 4, then block the exit of the patient circuit, and then allow the circuit to be saturated with the volatile agent. That way, it will take shorter for you to be able to equilibrize and reach a steady state. Emergence from anesthesia is still the same. If you have been using low flow, again, it has been found that if you don't titrate your medication well, or if you don't change your circuits, you are going to have a patient who will take long to wake up because the system will be having quite a lot of the inhalation agent with it. The other thing is that you have to be quite vigilant to make sure that you don't give hypoxic mixtures. And you realize that we were able to maintain our oxygenation FiO2 at around 24. If anything happens to cylinder or the gas supply, you might find that you are going below 21. And therefore, you are supposed to be always with the patient and checking and monitoring so that you are able to know at what time are your FiO2s falling below the expected to give you good oxygenation. The other thing that happens is that because of, again, low flows, you find that you have a lot of time for carbon dioxide to be absorbed, as opposed to when you're having very high flows. So what happens is that you find that your carbon dioxide absorption is more when you're having low flow. And there's a tendency for your soda lime or the absorbent you are using to get exhausted. So it is always important for you to be checking, to be looking at your carbon dioxide absorber to see whether it is changing color, whether it is whether your monitor is telling you whether you are breathing carbon dioxide or not, because that can be a real issue if you're not monitoring your patient. There is a high likelihood that you can get hypercarbia just because of using exhausted CO2 absorber. Now, what are the advantages? One of the things that you're able to do, or you're able to conserve, is heat and humidity. And these have been found to be very beneficial to our patients. We know the gases that we give to our patients are dry gases and they are very cold gases. So if you have got no way of conserving humidity and conserving heat, you might end up with your patients who are hypothermic and patients who are very dry because of that. But low flow has been found to be a very good conserver of that, and it is a very good advantage in physiology. Low flow has also been found to improve dynamics in the inhalational anesthetic gases. You know, the higher the flow, the more turbulent the flow is, and there's usually a lot of wastage in terms of as compared to laminar flow. So when you have low flow, your dynamics of flow are improved, and therefore there's no wastage of ventilation. The above humidity and heat have helped to preserve the mucociliary clearance and activity. They improve the epithelial health of your respiratory system, and they help to reduce accumulation of dried secretions or drying of secretions in your airway. So the fact that you are using low flow, you are not blowing out, you are conserving air, you are conserving your humidity, your water, have been found to be physiologically beneficial to the patient. Economically, again, the higher the flow you use, the more of the agent you throw out and waste. And as you have seen actually is that since you are expiring, let's say you are using isoflurane, and 99% of it can be reused, you find that there's a lot of economy in using low flow. And it has been found, studies done, that you can save as much as 75% of volatile agents. When it comes to ecology, you have seen that when you use low flow, you reduce your carbons, you use your nitrous oxide damage to the ozone layer, and therefore you preserve your planet. And the other thing is that you're reducing your greenhouse effects because you are reducing the emissions of your greenhouse gases. Environment, theater pollution. Again, some people have done studies, controversial studies, and one of them has been that sometimes the nitrous oxide has been blamed for bone marrow depression. It has been blamed for fetal losses. But the fact that your environment in theater has a lot of inhalational agents, by the time you are doing 3, 4, 5 children, or when you used to have the semi-open systems, you ended up being sleepy. Sometimes we don't know whether it contributes to accidents, whether it contributes to our being inactive, insensitive in theater. This can be reduced. You can be able to reduce theater pollution and the consequences of theater pollution by using low flow. So I'll just conclude by saying that we all have an obligation as professionals to be able to reduce contamination so that we can leave our planet a better place for our future generations. And for us who are there now practicing, who have got 30 years to practice, 20 years to practice, you need to practice in a safe environment. Thank you.
Thank you very much, Dr. Kabetu, for that very enlightening presentation. I'm sure, there's a lot, because people don't know, there's lack of awareness of use of low-flow anesthesia, and I'm sure there are many concerns regarding its safe use. And as a matter of fact, Dr. Njau has just asked a question, perhaps you could comment on it, because seeing that low-flow anesthesia incorporates rebreathing of the exhaled air, if you could kindly make a comment on compound A toxicity risk. Thank you.
Compound A?
Yes, compound A toxicity risk. Exposed from the use of inhalation anesthetics like sevoflurane.
Yes, I think there has been a lot of work that was done, especially when sevoflurane was produced. And one of the things that was in the manufacturer's document was for people to avoid low flow, less than 2 liters per minute, because of production of compound A when you use it with carbon dioxide absorbers. But studies that have been done have actually exonerated it being harmful to the human being. They said it is harmful to the rats, but the studies that have been done, they say it has got no effect on the human beings. That is one. And two, it was more found with people who use sodium hydroxide as the carbon dioxide absorber. But those who have changed to calcium hydroxide for absorption.
Sodium or potassium?
Sodium or no, potassium? It was potassium.
Potassium.
Yes, but it has been found to be safe when it has been replaced with calcium hydroxide.
Thank you. Another question. I think for those who have not, at least coming from your experience, because you've come from using high flows to moderate flows to now low flows, how would you say someone will begin, if someone wanted to begin using low flow anesthesia, what would be the safest way of becoming familiar with the different techniques?
I would say if you are giving at least 2 liters per minute of your anesthetic agents, especially when you are using nitrous oxide and oxygen, cutting it from 4 to 2, you have already saved your the anesthetic agents and pollution and everything by more than 50%. And more than 50%, it requires a very huge cost. If I imagine the number of anesthesias we give in the country or are given in the world, just by reducing by 50%, has been found to increase savings by 35% in terms of inhalational agents and in terms of pollution. Now, if you go to 1 liter per minute, that meaning that you are giving nitrous oxide or air 0.5 and 0.5, again, you have reduced and you are still safe. But as you go down to basal, as you go down to 0.25, as you go down to 3, you need to start now eliminating your nitrous oxide and introducing air. And as you go deeper or more lower towards 0, you need to increase your percentage of the amount of oxygen that you are delivering to your patient. So the safest is if you have been doing 4, go to 2. If you have been doing 2, go to 1. And by that way, you are going to also to become very brave, and you are going to start appreciating that you're actually doing a lot of good to the environment and to the amount of money that you use, because it has been quite wasteful when you are using 4 liters, 5 liters as your flow.
So that comment has generated 2 quick questions.
Yes.
And one is with regards to monitoring. A number of machines are not able to have, let's say, monitoring for the at least expired oxygen concentrations and gas agent monitors. So how you would, what you could comment on that with the machines that we have, majority of institutions. And then secondly, seeing that, yes, we say that there's an advantage to the environment, but there's the argument that anesthesiologists or at least anesthetists contribute very little to the global nitrous oxide generation. So what will your comments be?
Let me start by the global contribution of nitrous oxide. I have told you what happens. Nitrous oxide stays in the environment for 121 years. So I'm trying to imagine the 20 years I used high flow nitrous oxide by myself as an individual. I must have contributed a lot. If you multiply that with the millions of general anesthesias that we are giving, it means that we are doing quite a lot in terms of contribution. It's only that nobody sits down to look at how much we are contributing. But this is a good excitement. It is a good paper that can be worked on by our MD students to try and now look into it thoroughly, deeply, and especially in our environment. And this can be a very nice observational study of how our practice has been. But as far as contribution and nitrous oxide, even today, Britain uses about 27% of their general anesthesias have nitrous oxide. Other countries are still using nitrous oxide. And if they use it in low flow, I mean in high flow, one can tell you how much. Low flow, in terms of monitoring, when you start going below 1%, you need to be able to monitor your end tidal CO2. You need to be able to monitor your inspired oxygen. You need to be able to monitor your inhalational agents, the concentration that you are giving. And one of the issues that we have is leakage, because if you are not testing your machine for leakage, whatever you set and whatever the patient is getting might be too different, or they might be worlds apart. And it is always important that you are using a machine that has been checked for leakage. And for yourself, as the anesthetist, make sure that your circuit is not leaking when you have intubated your patient. And that is why sometimes it's very important for you to be able to use pressure controlled ventilation for pediatrics, because most of our pediatrics, other than the current teaching, we have not been using curved tubes, and therefore there is always a leakage. So my advice is that if you want to go below 1, you have to have monitors. I mean, you have to have equipment that can be able to tell you how much you are giving and how much is the output. Otherwise, you might end up with what we have been worried about, either patients waking up because they are not getting enough, or patients being deeply anesthetized at the end of the operation because they have issues with retention. But for us who are lucky enough to have modern machines that are there, I don't think we have an excuse. We can actually be able to be brave enough. And eventually, we know at the end of the day, when we standardize our practice, this can be able to happen in our environment.
Thank you. Now, the comment on the machines that are able to have gas analyzers and and oxygen concentration levels.
Yes, the types.
Yeah, no, I wanted to make a comment because we realized that with low flow anesthesia,
Yes.
you would require actually to have a gas agent monitor and one that monitors your inspired and expired oxygen concentration as well, so that to avoid giving hypoxic mixtures. So with the machines that we have, how feasible is it in most of our centers?
And now it's difficult to know what machines we have. I have seen what we have in Kenyatta. You combine both what the monitor is giving and what your machine can be able to pick. I think we have what, 30? Yeah, I'm saying it depends on the hospital you are working in, because the machines, especially the ones that are in high-end hospitals, you can be able actually to give low flows. They give you mark values. They're able to give you the expired and the inspired concentration of the inhalational agents that you are using. Unfortunately, most of our departments or our members anesthetists, we are never involved when a few of our hospitals are buying equipment. So we are not able to factor in all these important monitors and important aspects of our anesthetic equipment, either the physiological monitor or the anesthetic machine, for us to be able to. But coming from experience, up to 1%, you are safe giving, because 1 liter per minute, because it doesn't alter a lot in terms of your inhalation agents that you are giving. We know that most of the modern vaporizers that we use are compensated for flow between 250 mL and 10 liters per minute. So when you are giving as low as 1 liter per minute of your minute volume or your fresh gas, you have no danger of getting into very high flows or very low concentrations. Low concentrations of your product. The other problems comes if your machine is not serviced adequately or if there is leakage.
Thank you. I know you wanted to have this discussion also open to others who have the experience of a low flow anesthesia. And Dr. Njau, I think he's online. If you could kindly, Dr. Njau, if you could unmute and just comment on, can low flow really be universally applied to our patients? And is there a role of bispectral index monitors in low flow anesthesia? And how well do you know, how do you assess the level of wakefulness or awareness, during low flow anesthesia? Dr. Njau?
As far as the universal application of low flow anesthesia, I totally agree with Dr. Kabetu. You need a minimum head tidal CO2 monitor, and as well as an head tidal monitor for your inhalational anesthetic, particularly if you are using inhalational anesthetics. You need an head tidal monitor to be safely make sure that your patient is well anesthetized. Remember, if we go back to the issues of these monitors and other monitors for levels of anesthesia or depth of anesthesia monitors with processed ECGs, the initial studies had shown that actually if you use the head tidal monitor of your anesthetic, you were quite safe. So it is not a must that you must have your monitor on. Of course, in the West, the monitors have become a standard. Some of us don't believe in it. Probably we look at it from the advantage of the industry, the industry taking advantage of it, and not necessarily from the perspective of patient safety. Of course, it is said it improves patient safety. Now, when we come to the machines that you're talking about, majority of the machines that are available including the Wato 35s, that's the Midrays, and even the G machines and the Drager machines. If we looked critically at those machines, they can be upgraded, even if they did not come with the capabilities of monitoring the air tidal inhalation or anesthetic or air tidal CO2. So probably individually in your institution, it's something people can explore and propose it to the powers that be of the advantage of actually upgrading that machine, because it's purely software and some little hardware that is required, and give to them the advantage of actually having that upgrade and the reduction of in terms of cost of your inhalational anesthetic that you are going to be wasting by using high flow anesthesia in the absence of the upgrade. Now, moving from that, there are machines that are really high tech, and we have them in this country. Some which actually now have auto flow monitors, auto flow controls, that is. So all that you need to tell them is you give what you aim at as the mark of your inhalation or anesthetic, your combination of the gases, if you're going to give nitrous plus oxygen, or for some of us who don't use nitrous, if we can avoid your mixture of air and oxygen, and it will actually auto control the flows, and they can go to extremely low flows. I have done flows of even less than 0.2 liters, that is 200 mils per minute. So those machines do exist. They are actually in our country. Of course, they come with a bigger cost, and probably that's the direction the world is heading to, particularly the West, where we ourselves are not in control. Be very careful when you are using the minimal flow anesthesia, even if you have your air tidals. If you are doing 0.5, that is the minimum flow, 0.5 liters per minute. If you are doing that, kindly and be careful, don't monitor only the FiO2. Keep a very close eye on the air tidal oxygen concentration, not just in the inspired oxygen. So have the capability. If you are going to do minimal flow, note, if you are going to do minimal flow, keep an eye on your air tidal oxygen concentration. You find that, like the case Dr. Kabetu has demonstrated, if you don't keep that eye closed and all that you set is your FiO2 and you are keeping an eye on your FiO2, you may actually be dropping towards the end of the second hour to FiO2s of less than 20%. So that is something of note. In my experience, instead of, I don't usually change my patients from closed circuit. I keep my patients continuously on the closed circuit. And if you have the opportunity of using those high-tech machines, ones which have the auto, the minute you reset, you have the case has come to an end, and you actually reduce or switch off your inhalation or anesthetic to 0, then the machine automatically goes on high flow so that it can wash off the inhalation or anesthetic. I don't like my patients breathing on their own when they're waking up, because you have these patients getting atelectasis. The patients not make a good minute ventilation, so the rate of the wash of your inhalation anesthetic is much, much slower. And therefore, I prefer, probably, if I'm using a good machine like which has other modes of ventilation except the controlled, maybe I put my patient on SIMV, or I put the patient just on pressure support ventilation, and they wake up. So if you are doing that and you don't have the machine which has the auto flow control, then you need to go up on your flows towards the head. And it is recommended that you actually go back to now the high flow, that where you are going to more than 1 minute ventilation, because now you are not having inhalation or anesthetic, you're either purely on oxygen, or for some of us who don't switch or who use medical air, we can still remain on medical air plus oxygen, because anyway, the patient is going to breathe medical air. And if he has not been on nitrous, there's no risk of the diffusion hypoxia occurring at the end of surgery. So I just up the flows, keep the patient on the vent, and you can wash off your inhalation anesthetic much faster if you are on the vent.
Thank you very much, Dr. Njau, for that comment. Dr. Kabetu, did you have anything to add? We have just 5 minutes before we close the Q&A session.
I think the only question I have been asked is about complications in pediatrics. Again, for you to be able to give a 3-kilogram baby hypoxic mixtures, even when you are low, depends on the ventilatory effort the child is having or what method of ventilation you are using, because we have seen their oxygen consumption is quite low. You can actually go as low as 100 mL per liter, and they are not going to get into problems. So I think for us is to start the journey. We have actually weathered many issues with anesthesia. So starting the journey for low flow, we are not late. For those of us who have issues with the equipment, this is the time now we start advocating for good equipment for our environment, so that at least we can be able to contribute positively to the negative things that we have been doing as anesthetists.
Thank you so much, Dr. Kabetu, for that. I'm sure we've all been, it's been an eye-opener, even for myself. And I believe that now, because you've addressed all the concerns we had regarding its safe use. So as you said, for us to be courageous and to dive into this. So thank you so much for that discussion. All right, so enough in the next 2 minutes, I'm going to have Mr. Anthony Njau make his presentation, but just before then, Dr. Nabolindo had an announcement, just a brief one, and then we have the sponsor coming. Thank you.
Yeah, thank you very much, Dr. Abuya, for the opportunity. So again, I'm just making an announcement from the Office of the Executive Committee of the Kenya Society of Anaesthesiologists. First, we thank Dr. Kabetu and the organizers of the CME for this very timely CME, as we try to get on the bus with the rest of the world to save the world, really. So, yeah, so I was saying the announcement is from the Executive Committee of the Kenya Society of Anaesthesiologists concerning the upcoming 28th KSA and the 8th CCSK conference. So we had sent out information regarding the conference, and the emails that were sent out were to announce that we shall have a hybrid conference that was going to be a physical and a virtual component of the conference. So the dates for the conference remain the same. That will be 18th to 20th of August 2021. And because of the prevailing circumstances with the pandemic going on, and we are all privy of what is going on in the country, we are still at a volatile place where we do not know exactly where we shall be in August. So to aid the planners of the conference and also to be able to tie up things and work with the partners who help us with the conference, the executive committee has made a decision to have a fully virtual conference, meaning we shall not have a physical component of the conference. So bear with us. The communication has come late compared to the rest of the years, but it's because of a lot of things changing out of our control. But in the next coming weeks, you are going to get the communication coming with the plans going on. So thank you very much. Yeah.
Thank you. And we hope next year will be physical. Okay. All right. So Mr. Anthony Njau, please go ahead with your presentation.
Please confirm you can hear me, Dr. Abuya.
Yes, we can hear you very well.
Thank you so much for this opportunity. Thank you, KSA Executive, for giving us this platform to engage you further. And thank you, Kabetu, for the eloquence and the precise with which you did present this very important topic. I kept on hearing you talking about the accuracy monitoring when doing this low flow anesthesia. And I dare say that knowing the condition or state of the machine that you are using gives you comfort and assurance when doing low flow. And this includes the vaporizer that you are using. Dosing of the anesthetic agent must be sufficiently accurate in the low flow range, which in essence means the vaporizer must be properly calibrated. We know the actual vaporizer output is not what the patient actually inhales, but fresh gas flows, inspired flow carrier gas composition, mixing capacity of the circuit, the design of the circuit, the uptake, and many other things are all contributing factors. While gross errors in output, which are secondary to internal failure, might occur intraoperatively, that can be easily detectable by the gas analyzer. But nevertheless, vaporizer output must be regularly calibrated to ensure the patient is receiving what is actually dialed for the ultimate patient safety. So as Abbvie, we thought of sharing with you about our Vaporizer program so that you can know what we do in the region. And maybe if need be, you can reach out to us to enroll into this program. But first things first, the design of our bottle, it's unique, it's deliberate, it's designed to give you an innovative product, ready to use, ready and easy to use. I can say it's a plug-in and play kind of product. Not too heavy, you know, almost everything in theater is emergency and trays can or may fall as you prepare for the next patient. Also, it's convenient for use as no need for extra external fillers. So it's a quick fill system that is ready to use delivery. Does not require mounting of separate adapter by the staff. And it's designed to minimize the release of anesthetic into the room here. I think Dr. Kabetu spoke a lot about this. Then have we thought of the glass bottles breaking or maybe dropping and breaking in theater? Do we know the recommendation that once anesthetic or volatile spills in theater, what it's supposed to happen? So our bottle is a special pen bottle. It's a special plastic, which is non-breakable, lightweight and transparent, easy to recycle, which to hospital is cost effective. You can imagine the cost of disposing the glass bottle vis-a-vis the plastic bottle. So the quick fill system, it's a ready-to-use system for single-step filling of a vaporizer. And the bottle is only opened for anesthetic delivery when properly placed in the vaporizer receiving port. So you can see the picture there, trying to refill the bottle, no need of extra filler. It's a fully closed system as opposed to other open keen fillers. So Abbvie Alten a quick fill system, and this is how the system is. The bottle and the vaporizer both have a spring. The spring within the bottle is somehow weaker compared to the spring within the vaporizer. So what happens when you push the bottle, when placed like this and push the bottle. The spring within the vaporizer pushes, because it's stronger than the one within the bottle, pushes the spring up and the bottle opens up. So it's a closed system. There is no spillage. There is no exposure of the volatile to OR environment. And that contributes to also protecting the theater environment. I'll put this question to you, the anesthesia community. How often do we measure the atmospheric pressure, gases within theaters? Because sometimes you go to theater, it is noon or 1 and people are just sleeping, taking tea or lunch, and people are just fall asleep. What happens? Do we know why? Maybe that is something that the team needs to check. So what are the features of the quick fill system? It's a single step, ready to use vaporizer filling system. It is a spring loaded delivery system, as I explained, which minimizes risk of spillage and leakage. And it is convenient to use. It is designed to minimize release of anesthetic into the operation room. Kabetu did mention the effect of nitrous oxide. There are other effects, studies are there on the effect of even other volatiles to the OR staff. What are the advantages? And I've already mentioned about ready-to-use delivery system that does not require mounting of separate adapter, and no OR staff time needed to mount the separate adapter, and there is no cost for additional adapters. Then it is designed to minimize anesthetic exposure, as I keep on saying. So again, it is also designed to minimize the leakage and no risk of contamination to the volatile liquid by reused adapters. You know, some of these other adapters which are mounted on the bottle, sometimes you may run from theater 1 to theater 10 looking for the guy who has or technicians who has the adapter. And in between, there can be some risk of contamination. So these are some of the vaporizers which we use. These are our partners, General Electric, Draeger, Midray. This is Midray and Space Labs. So all these vaporizers, if needed in your hospital, we can very easily install. So why do we require vaporizer quality checks or oversight? This is for clinical accuracy, to ensure the vaporizer is delivering the correct concentration of the anesthetic agent. It needs to be calibrated, and that's why Abbvie annually calibrates all the vaporizers within the region. All Abbvie owned vaporizers within the region, we make an attempt to calibrate, and the ones which require servicing, we service them at least once every year. So again, it's for patient care. I know you know vaporizers are life-critical devices, and they provide you with the tools to give the patient the best care during the surgical procedures. Then again, it's for regulatory compliance. We are obligated to make sure that the vaporizers are maintained, calibrated. We always do audits every year. And also for increasing level of quality oversight. Some of the hospitals within Kenya and here the region are trying to at least to be listed as a JC high accreditation. Others are seeking for that. And this is a very, very important point to always make sure that your vaporizers are maintained and calibrated. Once the vaporizer does not meet the regulatory compliance, we always recall it and withdraw it from the hospital. So this is one of the vaporizer that we opened some times back. You can see the vaporizer, even the dial is marked using a pen. you can see the vaporizer is almost it's corrosive. And another thing is corroded. And another thing is that this vaporizer is not maintained and has not been calibrated for many years. So you can imagine how many vaporizers we have in hospitals. I am aware of hospitals who have vaporizers which have never been calibrated since they were bought. So you can see the type of vaporizers, and we are not sure what concentration these vaporizers are giving to the patient. So if you want maybe vaporizer in your region, in your hospital, you may want to onboard sevoflurane, or you may want to expand your use of sevoflurane. Those are contacts for our regional representatives. They can very easily attend to your requests. And maybe for Kenya, I need to ask or maybe notify you that KEMSA now is procuring sevoflurane for those hospitals who are not able to procure directly from the regional distributor or maybe Kenyan distributor. You are notified that KEMSA has sevoflurane, and my contacts are up there, Anthony, and if you need to install a vaporizer in your hospital, kindly give me a call. And in the next 2 weeks, I'm already trying to vet which hospitals. I'm in contact with several of them, and I'm trying to see which hospitals need these vaporizers so that I can assist. So thank you so much for your time.
Thank you, Anthony, for that presentation. We also look forward to having you down here in Kisii. We don't have sevoflurane, and we've been pushing for it. So
I'll be there next week.
Yeah, so I'm glad to hear that KEMSA has it, so we shall push for it. Thank you. I don't see any questions for you, so I think probably it was very clear. So asante for that. And I know I just have 3 minutes before the end of the webinar, so just 3 quick announcements. One, the webinar is being recorded and will be uploaded in the KSA Facebook page, YouTube channel, and their website. So you can catch that and any other webinars that you may have missed in the past. CPD points to the Kenyan doctors who are attending will be sent to you via email, and certificates for the nurses, clinical officers, and any doctors from without Kenya will also receive those in your emails. So thank you all for your engagement, for making comments in the chat, for all your questions. We thank Dr. Kabetu so much for his excellent presentation. All right, good night, everyone.